This episode of Precision Opinions Live is brought to you by Vintage Labs. Vintage Labs is a professional-grade supplement and cosmetic company where each product is tested and reviewed by one of their exclusive pharmacists. Look for the pharmacist's signature on every package that ensures that the active ingredient falls within 5% of error and does not contain arsenic, lead, cadmium, or mercury. We welcome you to join the Vintage Labs collection, where they do the research for your health. Use promotional code LIVE, that's L-I-V-E, to receive a 10% discount on all orders at vintagelabscollection.com.
Hey guys, my name is Henry from Precision Compounding Pharmacy. On this episode of Precision Opinions Live, we're going to be talking with Michael Gurevich, MD CA. He has his own private practice called Transformational Healing Solutions at 997 Glen Cove Avenue in Glen Head, NY, zip code 11545. You can reach him by phone at 516-674-9489. Some of Dr. Gurevich's certifications is that he's a Diplomat American Board of Psychiatry, Diplomat American Board of Addiction Psychiatry, certified by the American Society of Addiction Medicine. He is board eligible for Diplomat of Child and Adolescent Psychiatry, as well as being certified by the American Medical Holistic Association. Some of his previous professional experience consists of private practice in holistic psychiatry and integrative medicine, private practice in general, addiction and adolescent psychiatry, assistant director of psychiatry at North Shore University Hospital at Glen Cove, New York, consultant psychiatrist for chemical dependency outpatient clinics, consultant psychiatrist for adolescent day treatment programs, and consultant psychiatrist for inpatient dual diagnosis subunit for mentally impaired and chemical dependency. His education, Dr. Gurevich received his degree from the Medical School of Vilnius University in Lithuania. So without further ado, let me introduce Dr. Michael Gurevich and Christian Stella.
Precision Opinions Live. My name is Christian Stella, Pharm D at Precision Compounding Pharmacy. And today, actually, I'm with a special guest. I'm with Dr. Michael Gurevich. Dr. Michael Gurevich, thank you so much for coming on. I really appreciate you.
Thank you for inviting me, Chris. Thank you.
Good. So Dr. Gurevich and myself, we've been working together for a very long time in the Long Island area. And he brings something very unique to medicine. When I first met him and was introduced to him, he was so knowledgeable in his specific subtype. So you hear of psychiatrists out there. They're hard to find. I know that patients they constantly ask us for psychiatrists, and they're very hard to find in our area. You hear of functional medicine doctors and holistic physicians, but do you ever hear of them together? I don't think so. But this man does both of them. So I want to kind of get the background and your backbone of how you learn those two together, because it's really nice. And I don't know any other physician that's doing two of them together. So explain, Doc, if you don't mind, the pathway of your medicine background and how did you get into both of these fields?
Right. Chris, first of all, thank you very much for inviting. And I can tell you that we've been working for quite a few years, and I'm so pleased because kind of there are many compounding pharmacies, but you're very responsible. And the biggest area that I cannot find anybody to do is to compound some psychotropic medications. And I'm going to talk about that later. But you've been very helpful with that. So I really appreciate
that. That means a lot, Doc. Thank you.
Yeah. So I am I started my psychiatry practice in 1989. It wasn't even my first profession at the time. So after 5 years of residency fellowship, I was very excited. I thought I'm going to change the world and make every one of my patients to be well. And in spite of all my efforts, it didn't happen. What was happening actually that most of my patients keep relapsing. And I would put them on the best medication. They would be in the hospital. I would do ECT, electroconvulsive therapy. and they keep relapsing. So kind of I burn out very fast. And I began to look what else, what can I do? One of the things that I came up at the time, I was treating patients with alcohol abuse and all kind of other abuse. I found out about this 5-point auricular acupuncture, meaning you just put 5 needles in each ear in a specific points, and remarkably, patients would get well. They would come out of the hospital and they would continue to be sober. So
that's just 5 needles.
Just 5 needles, and it was kind of training that you can get in the Lincoln Hospital. It's called NADA. I don't remember exactly what it stands for, but anybody who is at the time who was in the field of addictions, and I was one of them, kind of could have done this training. So, but 5 points, but if you look at the ear model from Chinese or Western acupuncture, there are hundreds of them. So I wanted to learn all of them. So then it turned me to learn about acupuncture. And that opened my view that there are many other ways to help people. And what happens when you become good at something, you begin to attract more and more difficult patients. And it occurs, but it's a blessing as well. And so as I began to attract more difficult patients, the acupuncture 5 points or all acupuncture kind of was not enough. So I began to explore it. And I began to explore and learn multiple other forms of medicine. And it was guided imagery, meditation, then energy medicine, then transpersonal psychology, neural therapy, then IV therapy, energetic testing, keep coming, all these new modalities keep coming out. The latest one that I've been kind of exploring is the use of psychedelic medications, which actually now considered to be the kind of one final frontier in psychiatry. And that's where you've been very helpful compounding the ketamine for my patients. So, and my disappointments with conventional psychiatry, of course, grew more and more.
Yeah, so first off, I want to mention, you attract the misfits, and that's because you're so talented and you know how to deal with those very, very tough cases, which is why I like to see someone like you in that field. Now, ketamine, I would say I would consider it like the door into psychedelic medicine. It's letting everyone know that this is there, it's available. It really messes with, it could make the glial cells, the glutamate in the brain work a little bit better. So I'm very interested with that topic, and it's really gonna do amazing things for mental health. You mentioned, and now I would say it's kind of non-conventional right now. And you mentioned your disappointments, like you said that at the end. What would be your disappointments in conventional psychiatry? Why are you disappointed?
Yeah. Now, if you look at conventional psychiatry, it's probably 100 years behind the conventional medicine the way it is now. Let's say the Bible of psychiatry is so-called Diagnostic Statistical Manual, or DSM, where all the mental conditions are being categorized. And the way they are described is just by what complaints patient present or what psychiatrist is observing. So there are 2 issues here. And one of the biggest one is that it depends on the psychiatrist what diagnostic label they will give the patient. And it very much depends on the psychiatrist training, psychiatrist attitude, psychiatrist mood at the time. If you know about Daniel Kahneman, work. He is the only psychologist who received a Nobel Prize for economics. So his
Really?
latest book is Noise. And he talks, one of his chapters talks about this diagnostic statistical manual, and he kind of very critical of that, because if the same patient at the same day goes to several different psychiatrists, he will get 3 different diagnoses. So it's a highly inaccurate system. It depends, as I mentioned, on the psychiatrist's state of mind at the time, the questions with which psychiatrists will ask. And then it also variables on the patient. The patient may be in a bad mood at the day, so he will get a different diagnosis. Now, so this is first thing. The second, there is no objective measures for any psychiatric diagnosis. So it's very kind of depends on who is interviewing and when.
I would say it's similar to pain, correct?
Right. It basically, it's very, very subjective. So the same thing, it's basically regarding the medications. If you test the medications on a group of patients who basically have different etiology, different reasons that cause them their psychiatric diagnosis, but you give them the same stuff, you would not be able to get a good result. And most of the psychotropic medications are tested for just a very short time, just few weeks at the time. And basically the result, the outcome as compared with placebo is usually not more than 15 to 30%. And so it's a quite low response or remission rate, meaning those who get well. So that's where my issue is. Let me give you, and I'm going to try to give you some examples too. So about maybe 7 years ago, I saw this lady who was in her mid-40s. She was radiologist, a very gifted, very smart lady. And in her mid-20s, she was in crisis. Her mother was kind of dying. Her boyfriend left her. She was in medical school. She could not sleep. So she developed what looks like a manic episode. She was hospitalized for about 2 weeks, put on psychotropic medications. And then every time she would come for psychiatrist, she would get another dose. That was okay for 20 years. But then she noticed that her memory, and she was a very smart lady, noticed that she's forgetting words. Her memory is getting worse. So she came to me asking me what I can do. She was at that time on Seroquel. So it's an antipsychotic medication, which is being prescribed also for bipolar. So it took me some time to convince her that maybe we should try to get her off. And it took me a long time to overcome her fears. And then over several months, we very gradually decreased her medications. At the same time, I was helping her to resolve her psychological issues. She got well. She doesn't need any medications. Last time I talked to her on the phone a year ago, and it was because she needed insurance form. She's doing completely well.
Wow.
So
you don't hear those stories in medicine nowadays. You hear the stories of patients that get on something and they start feeling good. You don't hear getting off of something and starting feeling good. So I love to hear that. And now, a side note, is there anything that you use like on a natural side as far as supplements or anything that you would put a patient on, like L-theanine or magnesium, that may help them when they're being removed from these medications, or no?
Right. So one of the approaches, and I would like to talk about it more, is basically how to get patients off medications, and it is a process, and in this process I do use a lot of different tools.
Okay. Before you go into that, I want to kind of touch on what sort of condition. So you mentioned bipolar. Is there anything else that you would see that requires reduction or elimination therapy?
So almost any psychiatric condition is a fair game trying to reduce or eliminate the medication. Because as I mentioned, what if patient was put on medications in the first place for a wrong reason? What if they continue to be on medications and there is no particular need? So I would like to give every patient a chance to try to see if that is possible to get them off medications. Not everybody is, I cannot offer that to everyone. And basically one of the things, the longer patient stays on medication, the more difficult to get them off it. However, most of the, not most, but many patients can get off medications. Medication is not a natural part of what patient needs. This is a synthetic kind of thing that the body suppresses some part of the function and therefore causes some multiple side effects. So what conditions? Almost all psychotropic conditions can be fair game. Let me give you another example, and I would like kind of to illustrate. There was this patient, John. He came to me probably 6 years ago, first time, and he had several hospitalizations before. I did try to get him off medications, and as I began to decrease it, he just decided to take things in his own hands. He stopped medications cold turkey, and within 2-3 weeks, he was back in the hospital. And it took him another few months to come back to me. This time I negotiated with him again our contract that he has to be disciplined. He spent in the hospital several weeks. Then he was referred to a residential treatment facility, meaning his parents didn't want him to be at home because he was kind of, at the time, he was pretty aggressive. So it took us some time, and then very gradually over the next maybe 8-9 months, I was getting him down with medications. He was receiving intravenous therapy. There is this particular protocol called PK, which include phosphatidylcholine. So he was very diligent, coming every week for this IV therapy. And this was a very bright guy who had the memory, amazing memory. And because of the medications, his hormones were off, he gained a lot of weight, and most important for him, that his memory was off. So I was able to get him off medications over, probably took us, 8-9 months, but he's off medications. Once again, I rarely see him. His mom so appreciate that every Christmas she sent me some gifts and cards. It's very nice to hear. That.
That's so nice.
And the bright guy, he's now married. He's working.
What medication was that?
He was on Risperdal.
Okay. All right. So as far as your approach now, don't give away your secrets. I don't want you to do. But what's your usual approach for titrating these patients? So
basically, what we need to do, we need to, the number one issue, we need to find the etiology. What exactly have happened with the patient? Why patient needs to be on medication, or what happened in the first place? Because what we know that our mind, and our mind, we don't know exactly where it is located. You can dissect the brain, but we still have our mind. So actually, many things can affect our mind. So it can be a stressful situation, for example, a post-traumatic stress disorder. It can be an infection. It can be food sensitivity. It can be some toxicity. It can be toxicity of the medications. All of it can cause their mental issues. So basically every patient required to be very individual approach. So you cannot kind of have them all given the same stuff. It has to be highly individual. So let me give you an example. One of my first patients that I started in this office, his name was Chris. He was in about 22 years old. At the time he was in college, he began to use all kind of stuff, you know, as all adolescents in college. He became psychotic, very, very confused about his sexual identity. He was traumatized in his childhood. He requires several hospitalizations here in Long Island Jewish Hospital, require ECT. And I remember when he came to me, he was telling, "Doctor, you are my last stop." So one of the interesting factors with this guy was that he had 7 amalgam fillings. And as I tested him, I noticed that this is a big issue. So I referred him to a holistic dentist who took amalgam fillings. And the guy told me that this very interesting story. As soon as the last filling was gone, he felt like some sort of a radio station inside his head stopped working. And now he was free. So we were able to get him once again, very slowly giving supplements, giving, doing all kind of other stuff, teaching him how to meditate. He got involved in yoga. I was able to get him off medications. Once again, I have not seen him for years. At times, his parents still my patient. They come occasionally for some other issues. So I hear from them stories that he's got his PhD and he's happily married, has 2 kids, doing well.
Wow.
So the etiology is one of the most important factors, and there are multiple things. For example, I have now a patient who is on a small dose of Effexor. You know, it's anti-depressant medications, and
that one has a pretty bad withdrawal.
Yeah, it has very bad withdrawal, and basically, she herself tried about 7 times to get her dose down. She's a little bit obsessive, so she counts the pellets. Every morning she opens her
in the capsule, the pellets.
She opens the capsules, she counts the pellets, and she counts 52 pellets. That's what she takes every morning. So it takes, I don't know how long, but every morning she takes only 52 pellets. According to her calculations, it's about 19 milligrams. She's stuck on this dose for the last for a year and a half.
Oh,
because every time she was
that's a lot of work to do that, and it's not so safe, you know.
I know. This is a patient that potentially I probably gonna send to you to compound the Prozac when she is more ready.
Okay.
Anyway, she had a gluten sensitivity, and it was easy to diagnose just from her history. And she also had this hypoglycemia, meaning her blood sugar would fall down in the morning, and she would wake up at 4 a.m. all anxious. So I had to teach her how to change her diet. And after she changed her diet, it took us about 4 months to change her diet. Now we began to gradually taper her medications. So now from 52 pellets, now she is on 49 pellets, you know.
Yeah.
But this is somebody, and quite a few patients are frightened to get off medication because it's a big stress. Because when they stop medication suddenly, most doctors kind of not trained in that. Psychiatrists don't have training in how to get patients off medications.
No. I feel like they also will put a patient on a medication without knowing that this medication will cause withdrawals in the future if they need to get off of it. sometimes. That's what, like from my end, that's what I feel like I'm seeing.
Right. So another example would be, I have now very complicated patient, some patients are easy, I can get them off. Some patients are very complicated. This lady, she is she's in her early 40s, lives in Connecticut. She was stressed out and could not sleep, so she was put on Klonopin, and she could not get off Klonopin because there was stress, anxiety, whatever was going on. So psychiatrists promised to get her well by putting her on Zyprexa. It's an antipsychotic medications. On Zyprexa, she began to gain weight. So she began to complain to him. And he told her, okay, you don't want Zyprexa, let's stop it. And he stopped it cold turkey. She was on about 10 milligrams. She developed horrible insomnia. And for 3 years, this poor lady cannot fall asleep, and this is a complicated case, you see, and it's kind of, it's induced by psychiatrists who didn't have enough training, unfortunately, and didn't know that the medication can cause such damage, but that is happening.
It's a shame. I feel like there does need to be some more training in that area, as far as looking at longevity and safety over a long period of time.
Yeah, I agree.
Yeah. But that's great, and I appreciate you sharing these cases because it makes you kind of understand what these patients go through and why.
Right.
But as far as the titration schedule, when you get them on a titration, how long would you say it would go for? Like, how long is it going to take you? Let's just say you're going to take this patient off Effexor or any sort of SNRI or whatever it is. How long is it going to take you to get them off? Yeah.
So basically, it's an issue with every patient has to be taken individually. There is no kind of one measure, one shoe that will fit it all. Let's say recently I had a patient. She is in her early. I still have her. She's in her early 40s. She always been very anxious, tense, but with the COVID, a lot of people kind of became much more anxious. So she was put on lorazepam. And then, she read all kind of articles on the website that, medication is going to damage your brain and all kind of things. So she's trying to get off. And she can't. Every time she's lowering her medication, she has anxiety, what's going to happen. So she is kind of a simple case on lorazepam. However, there is no other pre-existing condition. So for about a month or so, maybe a little bit longer, I was helping her to address her anxiety. She also had postpartum depression at the time. And I use a number of things to help with that. One of them is neural therapy. It's an injection technique of local anesthetics. And I hope you're going to be able to soon provide me with procaine, which needed for that. So there are some very specific injections for this condition. So I resolved several stressors. After that, I instructed her how to reduce her medications. She was already on a small dose. She was cutting her lorazepam in about 8 pieces and decreasing by 1/8 of this 0.5 milligram. And she was able to get off within about 6 to 8 weeks. So it's a pretty fast. So that was an easy case. However, most of the cases are not as easy, fortunately, unfortunately.
And it makes sense. It's not cookie cutter at all. So you can have someone, I assume, that will drop 0.05 5 and they'll feel it, where some patients won't even feel it at all. So you need to tailor the therapy for that specific patient.
Yeah.
I get it, and that's what we deal with every single day. But now I know there's kind of a bunch of different ways to do this. There's liquids. You see, there's a lot of forums out there where patients talk and they get ideas. So there's forums where people would talk about using a liquid or a suspension to mix the medication, and they can physically dose based on a syringe. If it's 1 milligram per ml and they need 5 milligrams, they use 5 mLs. Very easy and simple to titrate down. Or capsules can be made, suppositories, creams, but I would say capsules and suspensions are most common. Is there any that you prefer, or is that something you leave up to the patient as well?
Yeah, so basically many medications luckily have liquid forms like Valium or Prozac and Celexa. So that becomes very easy. I would instruct them how to gradually reduce by a very small amount. And it very much depends on the patient, because some people are more resilient and they can tolerate bigger decrease. And some patients are very fragile and they cannot tolerate even the smallest one, 1/100th of a dose. The general rule of thumb that you cannot decrease more than 10% at the time. And the time, but once again, depends how frequently you can do it. People who are resilient, they can reduce it every 4 to 10 days by 10% of the dose. People who are not resilient need to do it maybe one every several weeks or several months. And I have those people for whom it took several years to get off medications. So you need to be patient. Basically, one of the most important things is to teach patients that as they go down with the medication, they may have some withdrawal symptoms. Describe to them what it can be, and then ask them to be their own observers and notice when something happens. And if that happens, then you need to slow down or hold on. Do not decrease your dose until you're completely stable. Some people become very impatient and they want to cut the dose because they think, oh, the last decrease was great, so now let me stop. This is a very kind of dangerous road. It's a minefield, and you can step on this minefield and be back in the hospital.
Yeah. So now let's just say a patient's having a withdrawal that is very severe. What are they at risk for as far as when they're just cutting a medication cold turkey?
Yeah, when they call it cold turkey, basically there are several factors which at times difficult to distinguish one from another. One can be just withdrawal, which will last maybe from several weeks to from several days to several weeks to several months. Some people feel like when they stop benzos, they still have a withdrawal several years later. And it actually described that there is a so-called protracted withdrawal. So you need to be careful of that. And it's sort of, it's part of it is withdrawal, and part of it is actually patient fear of being unstable again. So you need to distinguish where is a withdrawal and where is a recurrence of or when they go back to their old condition. Somebody who was anxious, after they stop benzos, they may go back to the anxiety because they did not resolve the reason that made them anxious in the first place. That needs to be addressed.
Yeah, so that's why I feel like it's very important to know who you're going to, and you need to go to someone like yourself if you're in one of these situations, because they can be very severe, and you are dealing with these withdrawal symptoms that can ruin people's days, weeks, months, and even like you're saying, years.
Right.
So someone like you, you're very educated in this field, and you have years and years and years of experience. I think it's beneficial to see someone like Dr. Gurevich yourself. But I just want to let everyone know, all the viewers, as far as Dr. Gurevich's information, 997 Glen Cove Ave. That's in Glen Head, New York, 11545. Telephone number is 516-674-9489. And email, Doc, do you have an email for the office?
Yes, it's Gurevich MD, like my last name, Gurevich MD @gmail.com.
And that's Transformational Healing Solutions.
Right.
The name of the practice.
Right.
Doc, I really, really appreciate you coming on. Thank you so much. And just like and subscribe. I appreciate it. Thank you.
Chris, thank you very much. And listen, thank you very much for working with me. And it's a pleasure to work with you.
Thank you, Doc.
Okay, great. Thank you.
Hello, this is Christian Stella from Precision Opinions Live. Please subscribe to our YouTube channel and like our social media links. You can reach us by email at compounding@precisionpharmacy.net or our phone number 516-785-4774, extension 2 for compounding. Thank you very much. Thanks for viewing.